Hello everyone, and welcome to today's lecture. Today we'll speak about a very interesting topic, which is actually two topics, which is esophageal atresia and tracheoesophageal fistula. So let's begin. So first of all, esophageal atresia. So it is a congenital malformation where the esophagus does not form as a continuous passage. We won't have a continuous passage from the esophagus. Instead, it will end in a blind pouch. For the embryology, during the fourth week of gestation, the foregut should divide into trachea and esophagus. But here, we will have a disruption that will end the separation of the trachea and esophagus that will lead to esophageal atresia. So this is what will happen. The esophagus should be a continuous passage goes to the stomach. Here we won't have this condition. It will end in a blind pouch. This is the pouch, and we will have a tracheoesophageal fistula with it, which is a part of the esophagus attached to the uh, to the to the trachea by a fistula, then continues to the stomach. Actually, have a different types of it. So this is the normal case. The esophagus goes. Wait, let me do the laser thing. The esophagus will go to the stomach. The trachea is alone. This is the atresia with the distal fistula. Here is the pouch, the atresia, and here we have a fistula. Here we have a pouch, this one, with a double fistula. This is a fistula, this is a fistula. Here we will have a separate, what's called atresia with the proximal fistula. This is the atresia and this is the fistula. This is only atresia. We'll have two pouches, and this is just fistula. The esophagus is line continues to the stomach, but we will have a fistula to the trachea. Actually, they divided to types A, B, C, D, E. I actually really hate this kind of classification. I mean, just save the it's like memorize the names. Why would you do A, B, C, D, E? So we already explained them all. Maybe just take a look about the types because it's actually important. They ask which type of fistula this, and they need the class, not the name. So the thing is, the most common one is type C, where we will have an atresia and a fistula, which is this one, atresia with distal fistula. That's this one. So this is just another picture. This is the pouch, and this is the fistula. So for the symptoms, first of all, we will have an excessive salivation and rolling, difficulty feeding and choking episodes, particularly when attempting to swallow. So dysphagia. Coughing and cyanosis. We will have a discoloration, cyanosis, due to the aspiration. Physical findings, inability to pass nasogastric tube into the stomach because we will go from the nose and we try to go to the stomach, but there is a pouch, it will stop here. So for the diagnosis, we will do a radiography. First of all, we will use the nasogastric tube. We will make it enter from the nose till the pouch where it stops. Then we'll do an X-ray to see what happens. We are here. Yes. So, and we usually have associated anomalies with it. So, as you can see, if you focus, this is a tube. So, it's a nasogastric tube. This is the end of the pouch. Here, the esophagus ends, and this is the stomach. So, as we can see, this is the nasogastric tube, this is the pouch, and this is the trachea. Here also, this is the nasogastric tube. It goes to the nose and comes here, and this is the pouch. So for the management, first of all, we do an initial stabilization, airway management to prevent aspiration and suction of secretion and avoid avoidance of feeding, because this fistula, the fistula attached to the in some cases. So the fistula which is attached to the trachea can pass things, either air from the trachea to here or food in some cases. In this case, for example, food can goes from, for example, if you have a GERD, it will go back and enter the trachea. In some cases, also this case, look, the fistula is attached immediately to the trachea. Food will come, it will enter here. We will have aspiration. It could lead to aspiration pneumonia or some diseases. And also in the reverse, we can have air going from the trachea to the stomach. So first of all, you do stabilization to prevent all these things. Then we need to do a surgery. Uh, it can involve a lot of things like anastomosis of the esophageal segments, or if it's so bad or the gap is significant, we should like make in our mind that we could need esophageal replacement. I will speak a little bit about tracheoesophageal fistula. We already spoke about it. I'm sure everyone understands it now, but we should speak about it a little bit as well. So, it is an abnormal connection between the trachea and esophagus. We learned this. Also, in the immunology, same thing. From the foregut, we will have a problem in the separation. And as we mentioned, type C is the most common one. The symptoms similar to esophageal atresia, but we can have recurrent aspiration pneumonia because we already explained why. Cyanosis are respiratory distress during feeding because they are connected together. Physical findings, as we mentioned, air may be heard coming from the stomach on auscultation due to the air passing from trachea through the fistula. Abdomen distension may also be present because of the air entering the GIT tract. GIT, gastrointestinal tract. So when we say GIT, we don't say tract. I'm not cutting that by editing. Diagnosis. So same, we'll do a radiography and we will see the same things that we saw in the esophageal atresia. Also, bronchoscopy sometimes performed to visualize the fistula directly. The management, first of all, we'll do also initial stabilization to prevent aspiration and maintain the airway stability. Then we should also do a surgery to repair the fistula and to solve the esophageal atresia because as we mentioned, type C is the most common, which have esophageal atresia and tracheoesophageal fistula. And we'll do a regular post-operative care. So we'll do a monitoring for the respiratory complications and the anastomotic leaks. Supportive care include nutritional support and possibly mechanical ventilation in the beginning. That's actually everything for this lecture. Thank you so much for watching. I hope you liked it and it was useful. Have a great day. Goodbye.